Great. Okay, yeah. So my name is Guevarra. Hopefully, I'll have the pleasure with working with some of you on pulmonary wards, but I am primarily a outpatient sleep physician, and I'm excited to talk about sleep medicine. It's actually pretty important, and hopefully, I focus this talk to be helpful for you guys. Most importantly, in your outpatient clinic. I'm sure a lot of your patients have sleep complaints and problems, and it's important to just be cognizant of things that can occur during sleep. So let me just get started here. So society in general just has a great apathy towards sleep. It's often something we sacrifice first in our lives, both for work, for our families, for Netflix and whatever streaming next. But sleep is actually really, really crucial. Before I talk about that, I think sleep in general is kind of bizarre. This is a great book by Matthew Walker, if you guys ever have time to read, that describes sleep and its importance. But in the beginning, he creates this scenario where a doctor describes what a newborn is to a mother for the first time. And he says, there's just one thing: from this moment forth, and for the rest of your child's entire life, you will repeatedly and routinely lapse into a state of apparent coma. It might even resemble death at some times, and while his body lies still, his mind will often be filled with stunning, bizarre hallucinations. This state will consume 1/3 of his life. So, sleep is generally like, why did we evolve to sleep so much? And I think that is the question. If we're sleeping, that saber-toothed tiger can definitely come and get us. So we're very susceptible. So why is sleep important? Sleep has a lot of homeostatic functions in our body. For example, it plays a large role in the function of the brain by forming new pathways and processing information. Research has shown that adequate sleep improves memory and learning, increased attention, and creativity in making decisions. Sleep is also the brain's maintenance system. So when we sleep, there's this glymphatic system where the brain sort of cleans itself out and removes neurotoxic waste. Channels in our brain allow CSF fluid to flow in and clear that debris. Another thing is, during sleep, our immune system releases cytokines, some of which promote sleep, and sleep deprivation may result in the increase of protective cytokines that are needed in states of stress or infection. So sleep also has a role in immunological memory. One study showed that after vaccinations after Hep A, sleep onset produces a strong and persistent increase in the number of antigen-specific Th cells and antibody titers. So pretty crucial in creating our immune response to vaccines. Sleep also, as we probably know, helps maintain the balance of hormones in the body, such as ghrelin and leptin. And these hormones regulate feelings of hunger and fullness and explain the link between inadequate sleep and obesity. Insulin regulation can also change with lack of sleep, which can promote metabolic syndrome. And also sleep plays a huge role in releasing growth promoting hormones, which play a role in healing and repair of cells, for example, in the cardiovascular system. I apologize if I sound out of breath. I'm almost 8 months pregnant, so my lung capacity isn't that great. I promise I'm okay. All right, just to overview what we're going to discuss today, I'm just going to quickly touch on normal sleep, talk about sleep studies, which you may be ordering in your clinics, talk about OSA, kind of focus on that because I think that's predominantly what you'll see. And then touch on narcolepsy, insomnia, and perhaps if we have time, talk a little bit about sleep deprivation, but it kind of encompasses everything we discuss. So what is the structure of normal sleep? There are 4 stages of sleep. The first one, stage 1, is sort of the transition between wakefulness and sleep. It is light sleep, and patients tend to awaken from this. And if they do, they don't perceive that they slept at all. and it should predominantly compose of 20% of total sleep time. Sleep stage 2 is the largest percentage of sleep, about 50%. Stage 3 is deep sleep, or really that really hard to wake up from sleep. And without it, people usually don't feel well rested. REM sleep is equivalent, as all of you probably know, to dream sleep, and it occurs less than 25% of total sleep time. This is proposed to be the stage where memory consolidation occurs. And then you wake up, and these stages sort of occur repeatedly throughout the night in about 90 to 120 minute cycles. And overall, we like to characterize sleep in two groups, non-REM and REM sleep. The reason of which being our physiology is very different between the two. During non-REM, there's decreased brain activity, reduced heart rate and blood pressure. We have a regular breathing pattern. We kind of tend to relax, our minute ventilation goes down, and we have a decrease in muscle tone. Pretty much the opposite happens in REM. It's more of a sympathetic nerve activity. Our eyes obviously have rapid eye movement. You have a irregular breathing pattern, and you're pretty much quote unquote paralyzed. Otherwise, we'd act out our dreams. So breathing is solely dependent on the diaphragm. How do we study sleep? So sort of the gold standard is something called a polysomnography. It's an overnight study, and it's crucial and very comprehensive in diagnosing sleep disorders. So during a PSG, the patient sleeps while connected to a variety of devices. There are EEG leads, eye electrodes to measure eye movement, especially for REM, EMG electrodes that measure muscle activity. All of these leads together help us determine the stage of sleep the patient's in. There are also respiratory indices measured by a respiratory flow sensor over the nasal, the nares basically. And there's also abdominal and thoracic belts to measure effort. Snoring is also detected with a microphone. There's a pulse ox. And we can also include a transcutaneous CO2 monitor, and then abnormal limb movements during sleep are measured by EMG electrodes in the legs as well as the arms. And then all of this information gets collected into a formal sleep study, which is read by your sleep physician. It looks very intimidating, and you wonder if patients can actually sleep through this. Surprisingly, some people sleep better in the sleep labs than they do at home. So we've been successful with this pretty much. The thing that has come out in the last 10 years or so are these plethora of home sleep tests. Often a full PSG is not really necessary for our question for the patient. And home sleep tests are really great for mostly if you're thinking about sleep apnea. They all come in different combinations. One is just a belt. Some of them come with maybe one EEG lead. Initially, a lot of them came with a nasal thermistor. But as you guys probably know, the one that we primarily use here is the WatchPad. It's a more novel device, but it's been out for a couple years now. And the way it works is it measures peripheral arterial tonometry, oximetry, heart rate, snoring, actigraphy, and body position. It uses the secret automatic algorithm that detects breathing events based on the tone of your peripheral artery. This generally increases along with an increase in heart rate and desaturation in response to respiratory events. And it has been validated for the diagnosis of OSA. Just a couple of things about the WatchPad. They're great for very straightforward OSA. If the patient's clearly snoring, you really have a high index of suspicion. It's really good at capturing that. It's not great for capturing anything else. So if you have other things you want to think about for your patients, if they're a particularly difficult pulmonary patient, hypercapnia, things like that, this isn't the ideal test. The overnight sleep study is. So it's kind of nice because it's really simple. There's nothing in the patient's face. and it's pretty easy to use. All right, so we're going to switch over and talk about sleep disorders. So let's start with the case. You have a 51-year-old male with a history of hypertension, and he presents with snoring. His partner states that he snores heavily, worse when he lies flat. He has episodes where he's holding his breath, gasping and choking. And every night he sleeps from 10 p.m. to 5 a.m., feeling tired in the morning. And he continuously nods off during the day. So that patient is sort of our classic obstructive sleep apnea type patient. And basically, in simple terms, it's characterized by recurrent obstruction of the pharyngeal airway during sleep, from sort of relaxation of your muscles, things that affect it we'll talk a little bit more about later, but like the shape of their tongue, the length of their soft palate, their adenoids, their tonsils, if they have nasal restriction, they're kind of more at risk for this. And then this results in hypoxemia and sleep fragmentation. In normal individuals, this can happen once or twice, but in patients who have severe sleep apnea, this can occur a multitude of times per hour. And we tend to see sleep apnea as the cycle of abnormal physiology that is occurring throughout the night. So a patient sleeps, they have decreased airway stability because their muscles tend to relax, the airway collapses, their oxygenation goes down, and they have an increased effort to breathe, followed by an arousal, which often leads to a release of stress hormones and increase in their heart rate and blood pressure. And then they may wake up completely, or sort of wake up into that light sleep phase. They open up their airway and is more stable, and then this keeps going on throughout the night. Most importantly, there's a fragmentation of sleep architecture, so whatever sleep they get is of poor quality and non-restorative. I just want to talk quickly about what we see in the sleep studies. I know this is pretty blurry, but these are sort of all the leads that we see. This is sort of our EEG leads, our I leads, our EKG. But what I want to focus on is basically, this is airflow and this is effort. And so obstructive events from sleep apnea are basically events where you lose complete airflow. That's an apnea, but there's an increase in respiratory effort. So these two events right here are obstructive apneas, and that's how we score it. There are things called hypopneas, which is a reduction of airflow, not completely flat, but enough to result in an arousal or a decrease in your oxygenation. So this is a decrease, and then arousals we kind of read from the EEG. We like to stratify the severity of sleep apnea based on how many apneas and hypopneas they have per hour on average. And less than 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, and greater than 30 is severe. Funny enough, this classification is sort of just convenient, I think, and I think the sleep physicians who created this needed some sort of stratification, but it doesn't necessarily correlate with the severity of symptoms. I have a lot of patients who have mild sleep apnea who have severely fragmented sleep, and treating their sleep apnea has completely changed their lives. And the same sort of like vice versa thing happening in patients with moderate or severe. So again, not necessarily correlated with symptoms. Patients with mild sleep apnea can still present with sleep fragmentation and things like that worthy of treatment. Okay, other consequences of sleep apnea. Bed partners are upset because they're snoring so loud, they sleep separately. They can cause mood disorders, depression, memory loss, confusion. It can also cause decreased work productivity and just basically quality of life. And the worst thing is motor vehicle accidents, which have occurred many times in the past. This is just a picture of a huge accident caused by a patient with untreated sleep apnea falling asleep at the wheel, so not to be underestimated. While successful treatment of OSA readily improves sleep quality, snoring, and daytime sleepiness, the relationship to other health consequences is not as clear. There are many randomized control trials that are limited by short-term outcomes and inadequate patient adherence, but certain relationships ring true. One of the most obvious relationships that research has found is its relationship with high blood pressure. Patients with sleep apnea lose the typical reduction in blood pressure you would see in normal patients during sleep, so your blood pressure usually goes down while you sleep. Whereas when you have sleep apnea, it can remain the same or even go higher. So treatment of sleep apnea leads to a reduction in blood pressure by an average of 3 millimeters of mercury. While that doesn't seem like a lot, they've shown that reduction of blood pressure by as little as 1 millimeter of mercury is associated with a decrease of major cardiovascular events, including stroke and heart failure. Anecdotally, I have this patient who had very hard to control blood pressure, but just with the treatment of her sleep apnea, she was able to go off all her meds. That's kind of a very rare situation. Usually what happens is you see a patient with refractory or resistant hypertension. They're on a couple of meds, you treat their sleep apnea, and they can wean off almost all of them and stay on one. Other things OSA has sort of an effect on is primary or secondary cardiac prevention, and this has been very controversial. A lot of the randomized control trials haven't been particularly conclusive with CPAP improving outcomes, but they're limited again by the adherence to the treatment, which is CPAP, as well as sort of short-term outcomes versus longer-term outcomes. There is a relationship with sleep apnea and stroke. There's an increased recurrence of second stroke after an initial event if a patient has untreated sleep apnea. And so we get a lot of referrals from neurology for patients who have sort of the phenotype of OSA and they had their initial stroke. Other things, let's see. Again, there's also a relationship with insulin resistance, poor glucose control in diabetic patients with untreated OSA as well. So when you're evaluating a patient with sleep apnea, I'm sure a lot of you already know this. These are sort of the risk factors. They're obese, they have AFib, or they have refractory hypertension, as we discussed. A lot of consults come from bariatric surgery because they've shown poorer outcomes in patients with untreated sleep apnea and also the driving population. What do you ask during the visit? You ask if they snore, if their partner says they have breathing pauses, do they gasp and choke at night? When they wake up, do they feel refreshed? Do they have headaches? Do they have a dry mouth? Are they irritable? Are they sleepy? Kind of very general questions. And when you evaluate patients, there are 2 scales that you may or may not be using. Both of them work pretty well. The Epworth Sleepiness Scale, as you see, is above, and the Stop Bang. Anything over 10 for the Epworth is abnormal sleepiness, and anything 3 or more for the Stop Bang, you would suggest referral to sleep testing. So the physical examination for sleep apnea, we know the Mallampati airway classification. The higher you are, the higher your risk is. Neck size also has an influence. You do it around the base of your neck. Anything greater than 17 inches in men and 16 inches in women suggests the possibility of sleep apnea. You look at their tonsils and also their jaw size. So if they have some retrognathia or micrognathia, that also increases the risk, creating more narrow oropharynx and airway. So I touched on this a little bit about ordering the right diagnostic test. Watchpad is often preferred if you really have a high suspicion. Contraindications include, a pacemaker, people with advanced lung disease, heart failure, if you really suspect central sleep apnea, neuromuscular disease, or seizures or movement disorders or anything else that you're looking for in the sleep study. We don't have the Santé, unfortunately, right now because of the pandemic. But the nice thing about it was we could also look for movement disorders. We can't for the WatchBat because there are no limb leads there. Okay, so treatment, as we all know, the lovely CPAP that all patients love and use all the time, just kidding. So continuous PAP is when continuous pressure. In order to do that or find the pressure that works for them, historically, it required another sleep study where they wore the CPAP and we figured out what pressure was great for them. And as we all know, it's very much limited by adherence issues. Now we do the auto-adjusting PAP, which is more common. We set a range for them. 4 to 20 is usually the range. And then the pressure goes up and down overnight to match the needs of the patient. For example, when they're lying supine, usually the sleep apnea is worse and they need more pressure. And so it goes up, but then if they're on their side, it could go down. It eliminates the need for titration usually and translates for lower overall pressures overnight. There are certain contraindications to PAP therapy: pneumothorax, head trauma, CSF leaks, ENT surgery if the patient's obtunded, obviously, and if they have bullous lung disease, as well as recurrent sinus and ear infections. That's sort of a relative contraindication. There are other treatments for sleep apnea. There's a mandibular advancement device. I describe it like a mouth guard for most patients, and what happens is when they wear it, it pushes their lower jaw forward, creating more space in the back of their throat. A special sleep dentist needs to make this for them. And classically, it's good for mild to moderate sleep apnea, not so much severe sleep apnea. The CPAP is really what's best for that. You could also think about surgery. This is sort of the classic one. It's called the UPP, and basically they shave off the back of the soft palate, the uvula, the tonsils. This is sort of a last resort kind of option. Doesn't work for all patients. I have patients who undergo this surgery and still need a CPAP machine, and recovery isn't as straightforward, so it's not the first thing I suggest. For patients with purely supine sleep apnea, you could have positional therapy. There are pillows that force you to sleep on your side. And then there are these electrical devices like a night shift that kind of buzzes when you're on your back, and then forces you to sleep on your side. The reason I don't love them is because a lot of patients have like shoulder issues, or it can exacerbate arthritis. So once that happens, then you're kind of lost for therapy. A lot of patients ask about the Inspire therapy. I think there's a commercial out there that makes it look pretty straightforward and easy, but it actually does require a pretty extensive surgery. What happens is you undergo general anesthesia, they place this neurostimulator, and there are 2 leads. One is the respiration sensing lead and the stimulation lead, which is attached to your hypoglossal nerve. And when the respiration sensing lead senses that you're taking a deep breath in or inspiring, it triggers the stimulation lead and it pushes your tongue outwards, creating more space in the back of your throat. And that happens every time you inspire. And again, it's sort of a, usually for those who have failed CPAP or standard therapy. There are a couple of criteria for it. A patient can't be, like, the BMI can't be over 32, their AHI needs to be moderate or severe. And it's the ear, nose, and throat sleep physicians that do that procedure. So I'm going to switch gears. Anyone have questions about sleep apnea? Nope. Okay, I'm just gonna go ahead. I don't know if I have enough time. Okay. So we'll talk about a new patient. Sorry, I'm having problems. Okay. So this is a 20-year-old female with severe daytime sleepiness for over 6 months and has a bilateral leg weakness for 1 to 2 minutes when she hears a joke or feels embarrassed. She sleeps about 9 to 10 hours a night, but requires naps daily. And she often fell asleep in class when she was in high school and college. She has episodes of waking up and feeling weak. She denies snoring or hallucinations. And sort of this is our classic narcolepsy with cataplexy type of patient. So what is narcolepsy? It's a chronic sleep disorder that causes overwhelming daytime sleepiness. Cause is relatively unknown. There's a known genetic link, HLA-DQB1. Some people think it's precipitated by a viral illness, strep, even the H1N1 vaccine, and head trauma. It's pretty rare. It usually comes on in the 20s. With a bimodal distribution, there's often a delayed diagnosis. So even though their symptoms start early, they kind of chalk it up to other etiologies, and they get diagnosed in their 30s and 40s. And then more common in men than women. And for some reason, it peaks in March when it presents, and birth order has some sort of influence in an increased risk with a third child or higher. I always forget that. I always forget to ask that question in patients. Anyways, so the symptoms for narcolepsy is obviously sleepiness, loss of voluntary muscle tone, that's cataplexy. We'll talk a little bit more about that. They have these hypnagogic hallucinations. What are they? They're sort of like when you wake up from a dream, you still think there's something in your room that looks like your dream, or you hear something when you wake up or fall asleep. Another common thing is sleep paralysis. They wake up unable to move, often residual from sort of like this blurriness between REM sleep and wake sleep. And surprisingly enough, even though they are so sleepy, their nighttime sleep is often disturbed and fragmented. So cataplexy is sort of pathognomonic for narcolepsy. If a patient describes this, it's pretty much you have the diagnosis. So how do you really describe it? It's hard. You kind of ask them if they lose voluntary muscle tone. These are sort of what they describe it as, I guess. And it's not always the classic, they collapse, they start laughing and then they collapse like the goats or whatever. Sometimes it can be very subtle, like their jaw feels weak or their arm feels weak and their head starts to droop. And it can even be like just slurred speech. And the emotional stimuli is usually positive, not negative. So it's not a fight or anger, it's usually something really funny if they laugh out loud. But it can happen with other emotions as well. Narcolepsy with cataplexy obviously is rarer than narcolepsy without cataplexy. And I'll show you how we diagnose that here. So how do we diagnose it? First, we have to rule out all other causes of sleep deprivation or sleep interruption. We have to rule out severe sleep apnea. We have to rule out inadequate sleep. So we have to make sure they're actually sleeping 7 to 8 hours a night, because sleep deprivation in general can cause a lot of the symptoms like sleep paralysis. And so each time we test them, we do a full polysomnography the night before, and then during the day, we do a multiple sleep latency test. So basically, it's this opportunity to nap 5 times during the day for about 20 minutes. So patients with narcolepsy, they fall asleep quick. So they have a short sleep latency despite having slept the night before, and they will quickly go to REM sleep during their nap, which is a hallmark of the disease. So this is sort of a graph looking at the sleep latency for people without narcolepsy. Their sleep latency is basically, in the teens. Narcoleptics, they're in sort of like 1 to 4 range. And again, they have REM sleep during their naps. So type 1 is narcolepsy with cataplexy, essentially. Type 2 is narcolepsy without cataplexy, and is it diagnosed if their mean sleep latency is less than 8 minutes during that study, or they have 2 or more sleep onset REM periods, and they have 2 or more sleep onset REM periods on the MSLT. So hypocretin, also known as orexin, is a wake-promoting hormone. And patients with type 1 will have a very low concentration of hypocretin if you do an LP. That's another way to diagnose type 1 or type 2 narcolepsy. Okay. So the treatment for narcolepsy is often stimulants. Traditionally, we had just sort of the amphetamines and methylphenidate, which come with a lot of side effects, as you all know. Now we have wake-promoting agents like modafinil and armodafinil. The mechanism of action isn't as well known. They likely think it has to do with dopamine reuptake inhibition, but it's nice because it doesn't have like sort of as bad of a side effect profile as the traditional stimulants. Unfortunately, it has no effect on cataplexy, so you need to use other medications for that. And solriamfetol is a newer medication that acts as a norepinephrine and dopamine reuptake inhibitor. In contrast to other medications, it doesn't interfere with birth control. Modafinil and armodafinil interfere with birth controls, so they need to be in like a barrier contraception if they are trying to prevent pregnancy. There are other stimulants. One is something called Wakix or pitolisant that work differently. Pitolisant works by blocking histamine. And the nice thing about pitolisant is it works both for hypersomnia as well as cataplexy. So there's a lot of stuff we can consider in our arsenal now. Oh, I did put it here. Okay, great, there it is. And then there's one medication called sodium oxybate, which works again for both hypersomnia and cataplexy. It is a scheduled substance, and it's essentially the equivalent of GHB or the date rape drug, which gives it a really bad reputation, but it works really great for a lot of patients. And it's basically a medication that you have to take divided in 2 at night. So you take it right before you go to bed, then you have to wake up and then take it again for it to actually work. So that kind of interferes with, patients don't really like having to do that, but it's shown to really work well for these difficult to treat patients with narcolepsy. Okay, for cataplexy, there are other medications for cataplexy alone, such as these antidepressants. Okay, the last case is a 34-year-old female with trouble sleeping for almost 5 years, almost every night of the year. She goes to bed at 10, doesn't fall asleep until midnight. Her mind races. She wakes up all throughout the night. She's self-medicated with melatonin, probably Benadryl and alcohol. No snoring, no daytime naps. And so this is your insomnia patient. And I'm sure you hear a lot of this from your patients in clinic. So there are 2 ways we think about insomnia. We group them into chronic insomnia or short-term insomnia. Chronic insomnia is 3 nights a week, greater than 3 months. They must have difficulty initiating or maintaining sleep. They wake up earlier than desired, and then it has to impact their day-to-day life. Otherwise, obviously, it wouldn't be considered insomnia. So there are different types. Psychophysiologic is sort of the big bucket of everything. Usually these are anxious patients. They can't fall asleep. They adopt very poor sleep habits, and it's like a vicious circle. Paradoxical are these patients who really believe they don't sleep, but then when you do a sleep study, they sleep 8 hours, thinking they only slept 2 hours. So it's sort of managing their expectations or telling them, you know what, you do sleep even though you feel like you don't. Other things they can be associated with mental disorder and inadequate sleep hygiene. Short term is less than 3 months. The most common is adjustment disorder. Usually there's maybe a death in the family and a new move or a new job, a new stressor, and often resolves on its own. So general management sleep hygiene, I'm sure you all know this. You sleep and wake at the same time every day, very crucial. You avoid alcohol, nicotine, caffeine, especially near bedtime. You don't do anything very activating right before sleep. You avoid bright lights near bedtime. You can use blue light blocking glasses. You use the bed for sleep and sex only. You don't stay in bed awake, anxious about sleeping, because that creates like a poor association of the bed with anxiety. And then you maintain a clean and comfortable sleep environment. What's all the rage now with my patients? They like weighted blankets. I don't know how well those work. We tell them not to watch the clock, not to stay in bed awake, not to exercise 2 hours close to bedtime. So, I mean, those are the things that I usually have time to emphasize during the initial visit. Other things that are important are, you know, if a patient comes to me and says, I don't have trouble sleeping, but I have trouble maintaining sleep, then I start thinking maybe there's something physiological that's waking them up. And I usually, at that point, try to rule out sleep apnea or anything else that could be interrupting their sleep. Okay. So the best management for sleep apnea is something called cognitive behavioral therapy, which I'm sure you all know about. There's something specific for insomnia in general. Pharmacological management of insomnia does not usually last long term. And studies have shown only CBT results in sort of a long-term effect and a more permanent resolution of sleep apnea. Like with all therapy and mental health treatment, it's often really hard to find a specialist to do this. And I think in Mount Sinai, there's only one at Maine Mount Sinai. So generally, I try to do what I can during the subsequent visits. Okay. So as we know, CBT is basically changing patient beliefs and attitudes regarding sleep. And there are a couple of therapy components that we use listed here. There's stimulus control. We strengthen the bed and bedroom as a stimuli for sleep. For sleep restriction, it's one of the more powerful tools. Basically, you limit the sleep window for a patient. So for example, if they're in bed unable to sleep from like 9 to 5, then you limit their opportunity to sleep from 12 to 5. And then once they're able to consolidate their sleep between 12 to 5, which they eventually do because the body can't function without sleep, then you sort of open the window gradually from like 12 to 5, 12 to 5:30, 12 to 6. It works really well if a patient sticks with it, but it's really hard for them, especially if they have obligations during the day. So sometimes I recommend it during vacation or something like that. And there are other things like cognitive therapy, if they really believe they can't sleep, anxiety, things like that. That's important. You teach them some relaxation techniques and again, emphasize sleep hygiene. So if we were to, it's hard to have a patient really report that they can't sleep and they're so miserable. Then you basically tell them to go home and restrict their sleep or do something behavioral that takes a little bit of time. So I'm kind of the mindset that I do something temporarily for them and I give them a temporary medication with the goal of once the behavioral therapy kicks in, we can quickly wean off these medications because they're often they're controlled, they're controversial. People have found like Ambien and these non-benzo medications for sleep can be associated with mild cognitive impairment if they're using it chronically. There are also side effects. So usually I try not to emphasize the importance of pharmacological management and always have the goal of weaning off them. But if we had to choose, I like this algorithm. I think it works pretty well. So like I said, behavioral interventions first, and then you kind of talk to the patient, try to figure out what exactly is their problem with sleep. So if it's really they can't fall asleep, these are the medications we look at. They can't stay asleep, these are the medications that help consolidate sleep. Because of all the side effects of these medications, there are specific medications that are great for older adults. And also a lot of the medications that we use have the dual benefit of also treating depression as well as insomnia. So just to talk about them, the ones that aren't controlled, melatonin, which is often not used correctly and is over the counter and usually doesn't work for anybody. There's also Romelteon, which is a form of specific melatonin. I think it targets melatonin 1 receptors that is prescribed and works a little bit more potently without sort of the side effects of generalized melatonin that you get over the counter. That also is not controlled. Doxepin is an antihistamine as well as an antidepressant. It works really well for sleep maintenance, and it actually shows less side effects for older adults as well. Also not controlled. And Mortazapine, as we all know, or Remeron, which is initially an antidepressant. A depressant, we give it to patients on chemo for hunger to eat, and sort of that's the ill effect that you can gain weight on it. The controlled medications are mostly non-benzo receptor agonists. It's like Ambien, which we know, Lunesta, and Sonata. So major side effect of Ambien has a black box warning for sleepwalking, sleep eating, sometimes sleep driving. So these are things you need to look out for. And I did want to sort of highlight that there are new medications for insomnia. I guess not that new. Suvorexant and lemborexant, and the way they work is they're orexin antagonists. I don't know if you remember from my narcolepsy portion, but orexin promotes wakefulness. So if you block it, the opposite will happen. And the nice thing about it is they've done specific studies, particularly for suvorexant, on patients with Alzheimer's disease and elderly patients, and it has a pretty great side effect profile. The biggest thing I encounter is it's hard to get it approved for through insurance because they're kind of in the newer class. So I think that's all I have. Okay, just a quick summary. Sleep is wonderful if you can get it. Sleep apnea is very common. Narcolepsy is a rare diagnosis marked by a dysregulated sleep-wake cycle and profound sleepiness. And then treatment for insomnia should focus on behavioral interventions rather than pharmacological ones. Okay.
I have a question. You mentioned that we frequently use melatonin improperly. Can you go over like the appropriate usage? And you mentioned also some side effects. I wasn't aware it has side effects.
Okay. Yeah, so basically, obviously melatonin is usually over the counter and not FDA approved. I guess that's what I meant. So like if a patient buys, some people are like on 15 milligrams of melatonin and then they say it doesn't work for me, but we just technically don't know how much melatonin is in each pill that they get over the counter. And in the sleep medicine world, if you do prescribe melatonin, you prescribe it in a range of sort of 1 to 5 milligrams. And generally melatonin is a better circadian rhythm regulator than a sleep promoting agent. So for example, if you have a patient with jet lag, you use melatonin. If you have a patient with a delayed sleep phase, like they like sleeping at 2 a.m., you would sort of use melatonin to adjust their circadian rhythm rather than use it to promote sleepiness. And usually what I find is patients just tend to feel very groggy in the morning. They either feel nothing or they feel very, very groggy in the morning and don't like the feeling of melatonin. Does that answer your question?
Got it. Yeah. Thanks.
Just to follow up to that, I noticed that like the dosages in the hospital are like 3 milligrams typically, yeah. But like the dosage that actually works is like 0.5 milligram. Like yeah. That if that was fixed, that could alleviate a lot of those side effects.
I think so. Yeah, if they take a lower dose, for sure. Sometimes there are a rare handful of patients where it magically works. Those are the best. But usually if they say, melatonin works a little bit for me, I go for the Romelteon or the Rosaran. Yeah. Rosaran? Yeah, the Romelteon which is a more specific melatonin agonist.
And are you a believer in the Mortazapine, like 2.5, 3 milligram dosing? I heard that really helps.
I don't know if I'm if that, I've never prescribed it that low. But I have heard of other sleep doctors saying it works pretty well at that dose with less side effects. Mortazapine, for a lot of patients, for some reason, at doses of 15, they tend to develop restless leg, which is something I tend to look out for when I prescribe that.
Thank you.
You're welcome.